Good morning, good afternoon, and good evening all. Once again, a very warm welcome on behalf of MYT. We're very much looking forward to supporting you with today's Health Campaign Effectiveness Coalition session on Lessons Learned on Collaborative Planning of Health Campaigns in Nigeria. And I'm now delighted to hand over to Chris to welcome you to the session. Thank you.
Thank you so much. Good morning and good afternoon to all of our guests and distinguished presenters. Thank you so much for taking the time to be with us today. I'm Chris Sarlis. I'm the director of the Health Campaign Effectiveness Coalition, and I'm really excited about today's webinar on the lessons learned in collaborative planning and health campaigns in Nigeria. We're seeing that a lot of people are just signing on right now, so I want to give you a minute to get settled, put your name and where you're coming from in the chat. As you heard in our introduction, we plan for this to be a really interactive presentation today. So just to get started, we're going to start with a poll to learn a little bit about your experience. I want to pop that poll up for us. Just give us a few seconds. We've just got a question or two for you. Okay, so your poll question is collaborative planning of health campaign part of your work? So first of all, are you engaged in health campaign collaboration? You think you're going to be engaged soon? You maybe worked on it in the past, or you're just interested in here to learn. So vote on what answer responds best with your experience, and we'll see what our audience is coming from today. So I want to just take a few minutes there. And I see a lot of people welcome putting your names and your location in the chat. So I'll give you just a few seconds to get responses up. Okay, do we have any results yet? I'm not seeing them. What does that look like? Okay, very good. So far, it looks like about half of our audience is engaged in collaborative planning for integration. Some are planning, quite a few have worked in the past, and many of you are here to learn. So thank you very much for answering this question. So I wanted to get started. For many of you have probably joined us in the past and you know about the Health Campaign Effectiveness Coalition, but for those of you who are new to us, I want to give you just a bit of background on who we are and what we're doing before we introduce our speakers today. So the Health Campaign Effectiveness Coalition was formed just early last year with funding from the Bill and Melinda Gates Foundation to the Task Force for Global Health. And this coalition was launched with input from many stakeholders from across various different health campaigns of immunization, malaria, neglected tropical diseases, polio, vitamin A supplementation, country participants, various donors and global organizations that work in health campaigns. We came together and this group created a vision for the coalition, as well as a theory of change, and identified 3 strategic approaches that we're going to be working on in the coming years. The key part of our vision, and I won't read it for you here, is we really believe that health campaigns are part of the health system and part of primary health care. And we see finding ways that we can use a strategic balance between those health campaigns and routine and primary health care services to achieve and sustain our health-related development goals. The coalition aims to foster improved collaboration between our country leaders, our donors, global organizations, and implementing partners. And you're hearing about that collaboration in Nigeria, which is leading the way today. We also support some implementation research that will help us identify and test and scale up those most effective campaign practices and approaches. And again, you can find information about our research and learning agenda, as well as information on these research awards on our website. And Sarah may be putting the link into those resources in the chat for you. We have 18 country awards right now, and we're very pleased that we're hearing from 2 of them today. We also know that those findings need to really be used to affect policy alignment and collaboration between our global actors and our countries to improve policies around funding and support for countries around campaigns. So this coalition is really looking to achieve these various approaches with countries in the lead. Next slide. Thank you very much. So in today's session, you're going to be hearing from two of our research projects. And again, we wish this to be as participatory as possible and encourage you to write comments in the chat and to use the Q&A function to pose questions throughout the session. We're really fortunate, in addition to having speakers from two of our case studies, also to have distinguished remarks from leaders of Nigeria's Federal Ministry of Health's Malaria Elimination Program, and also the Executive Director of the National Primary Health Care Development Agency in Nigeria. We hope you stay for the duration of the webinar so you can hear their remarks. Next slide. So what do we mean by health campaign integration? We've been using this term in our introduction and some of our things, and when we've came together last year, this was an issue that many of our stakeholders said they really wanted to learn about. How do we do integration? What does it really mean? How do we define it? What are some of the best practices? So our team came together to create a technical brief to identify some of those best or promising practices that we learned about. And to be quite honest, the literature was a bit scarce. So one of the reasons we're here today is that we are funding different projects in many different countries to explore what does it mean to do campaign integration and how do we define it? And one of the things that we're learning is it's not a one size fits all. It's a spectrum of various different approaches, and it's going to mean something very different for our different programs and our different country context. And we need to keep that in mind. One of the things we can do is just work on how do we better collaborate and share different campaign inputs. We're calling that sort of partial integration. And then on the other far end of that is sort of our co-delivery. But campaign integration can be various things along that spectrum. And that's some of the things that we're learning from Nigeria today, as well as some of our other projects. Next slide. We all know it's difficult to get started on new approaches. And so we began our research funding around eight case studies around campaign planning. And the purpose of these studies was really to support country institutions to help them facilitate that planning process, to bring different stakeholders together and to document their lessons learned and think about how those promising practices can be applied to different contexts. We know that planning can be difficult, so we really want to learn about the process of bringing those stakeholders together. What are the decision factors that different campaigns and countries use to decide how and when they can collaborate? What are the different perspectives? And what are the different metrics they're using to define success? Next slide. So as I mentioned, we have 8 projects in 6 countries. These are short case study awards, and they span various different regions and across several different campaign domains. The first 2 countries that are sharing their results from these awards is Nigeria. Next slide. Thank you. Our 2 case studies in Nigeria are going to be presented today from Ibolda Health International and the Clinton Health Access and Initiative, and you'll hear introductions of these 2 programs shortly. But I really want to thank them in advance for being the leaders and completing their case studies in such a short amount of time. Also to be willing to share these case studies are really, I want to say hot off the press, but this is the press right now. They're just wrapping up and you're the first to hear their findings. So we really want to appreciate them for taking the time today and also for the real innovative work that's going on in Nigeria. I'd like to now introduce our moderator for today's discussion. Next slide. Dr. and Professor Olamide Ogunawusi is a professor and director of research, innovation, and development at the University of Medical Services in Ondo City, Nigeria. Dr. Olamide's career spans more than 3 decades in public health and research. In his current role, he promotes implementation research as an essential field for optimizing delivery and effectiveness of health campaigns. Previously, Dr. Olamide was a scientist with a special program for research and training in tropical diseases at WHO's headquarters in Geneva, where he led the implementation research initiatives with middle and lower income countries and developed WHO's TDR implementation research toolkit. Please take a chance to look at that toolkit when you get some time. It's really very helpful, and we're using it as a basis for many of our work. We're extremely thankful for Dr. Olamide to be with us today. He's a member of the Health Campaign Effectiveness Scientific and Technical Advisory Committee, and I'll turn the mic over to you. Thank you very much, everyone.
Thank you very much, Chris. And again, welcome to you all. Good morning, good afternoon, and good evening, wherever you might be. This in a short while, we'll be hearing from 2 projects in Nigeria about the lessons they've learned in collaborative planning for health campaign programs. They will share with us their insights and how they have documented and facilitated convening with stakeholders in the collaborating planning of their integration campaigns. We would then have a brief presentation from them. We would hear the lessons learned by each team, and this will be followed by focused questions from the audience. I'd like you to feel free to send your questions into the Q&A box. I will attempt to answer them before the end of this session. So again, as Chris did mention, from Ibolda Health International, I'm pleased to introduce to you Dr. Ali Johnson Onoja, PhD. He is chairman of the Ibolda Health International Limited and CEO of the African Health Project and Ubillion Nigeria Limited. Along with him also is Dr. Dele James Babaride, who is PhD also and CEO and president of Ibolda Health International. They will be giving the first presentation. The second one will be from Clinton Health Access Initiative, CHAI. And for CHAI, I'm pleased to introduce to you Dr. Ms. Kikelomo Lambu. She's the vaccines program manager with CHAI. She's the project lead, supply chain and health system strengthening specialist. At this point, I would like to turn over to Dr. Onoja and ask you to please go ahead with your presentation. Dr. Onoja.
Hi, everybody. My name is Dr. Ali Johnson Onoja. I'm making this presentation on behalf of Ibolda Health International. The topic of our presentation is an exploratory process evaluation of potential collaborative planning of malaria interventions, insecticide-treated nets, and seasonal malaria chemo prevention campaigns in Gombe and Jigawa states in Nigeria. This research project was conducted by Ibolda Health International in collaboration with the National Malaria Elimination Program. Problems and opportunities to be addressed and research questions. Problems and opportunities. Malaria remains a major public health problem in Nigeria, despite being preventable and treatable. It is endemic throughout Nigeria, with 97% of the population being at risk. ITNs and SMC campaigns are 2 key preventive strategies employed in Nigeria as one of the strategies for malaria elimination in the National Malaria Strategic Plan, NMSP 2021 to 2025. Both ITN and SMC campaigns are being considered for integration due to some similarities observed in the planning, implementation, and post-campaign phases for cost efficiency and avoidance of duplication of efforts. Research questions, primary questions. When do we place order for the commodities? The lead time for the expected time of arrival of commodities, and how do we track the progress in manufacturing and shipment of commodities from origin of manufacture to last destination? What are the facilitators for a successful campaign integration? What are the structures in place to facilitate the integration of campaign processes and phases? Secondary questions. What are the changes to be made on the tools? Messaging. What components will remain as standalone? Who are the key players to avoid duplication of roles? What are key cost-saving points in the entire process? Research methods and approaches. Desk review. The methods include desk review of reports, lessons learned, secondary data analysis of existing qualitative data from ITN and SMC campaign distributors, early consensus building meeting with all relevant stakeholders towards the case study process evaluation. We reviewed ITN and SMC campaign timelines, engagement meetings. This included engagement meetings, micro-planning and distribution on the planned standalone campaigns. The study deployed a qualitative methodology using guides of key informant interviews and focus group discussions. 91 KIIs were conducted on the whole. We also conducted key informant interviews, observation of key activities using guide and checklists, analyzed KII and FGDs, including SMC coverage data to inform findings and recommendations. Engaging key stakeholders. Ibolda Health at the NMEP, Ibolda Health met with the National Coordinator NMEP and secured the support to conduct the process evaluation in Gombe and Jigawa states. NMEP sent an official letter to the states to participate in the qualitative data collection and facilitated entry meetings. NMEP also reviewed the data collection tools and case study reports. The State Ministry of Health top-level officials accepted and understood the importance of collaborative planning of campaign integrated based on the role played by NMEP in engaging and raising awareness on the process evaluation. The subnational level actors participated in KIR and FGD as respondents. Implementing partners, NMEP provided adequate information on the process evaluation to both IVM subcommittee and SMC working group and participated in the KII as respondents. These are some of the pictures that occurred during the process of study implementation. Key findings: integration is possible and can be seamlessly implemented and achieved, having successfully a good collaborative pre-planning and planning activities. The process may lead to strong or improved outcome for ITN and SMC coverage and use following integration in collaborative planning and effective utilization of resources, material, human, and finance. Collaborative planning can bring about an increase in collaborative demand for both ITN and SMC campaign commodities. This is due to the fact that integration creates a psychological feel for double benefits, having to receive both commodities at the same time. At least 12 months period is required to begin active engagement with key stakeholders at the national and subnational levels, which will facilitate effectiveness and efficiency in micro-planning phases and resolve unforeseen bottlenecks. Challenges faced: confusion over the concept of integration, inadequate federal, state, and FGA government funding leading to overdependence of donor fatigue, health intervention happening same time using same pool of personnel and all that, different target groups of the intervention leading to longer time spent in the household. The mitigation includes, as listed on the slide, and includes high-level advocacy to all levels for buy-in, counterpart funding, and fund releases for campaign. Also includes all the other factors needed up to secure ownership of the integration process by the State Ministry of Health. Promising practices: early engagement and consensus building among government partners, key stakeholders led to better understanding of the importance of campaign integration. Effective coordination support to campaign integration through ITN, expert group, and SMC working group, and the willingness to support pilot implementation of ITN and SMC campaign integration from collaborative planning to determine if an integrated campaign will work. All the other factors are listed and include leveraging on lessons learned from previous standalone campaigns on pre-planning purposes. This is a map of the study sites of Jigawa and Gombe. Thank you very much.
Thank you so much, Dr. Ali Johnson Onoja. We'll come back to you with questions and discussions in a little bit. So I'd like to call on Ms. Kelomo Lambo to tell us some of the work that CHAI has also done, CHAI has also done, and we'll listen to you now. Ms. Lambo, you have the floor.
Hi, everyone. My name is Kelomo Lambo, and I'll be sharing findings from a study conducted in Nigeria focused on learning lessons from the implementation and planning of integrated campaigns in the country in the context of COVID. This case study was conducted by the Clinton Health Access Initiative in collaboration with the National Primary Healthcare Development Agency, an agency responsible for delivery of primary healthcare services and immunization program, amongst others. When this integrated campaign was conducted in the country, the incidence rate for measles was 33.6 per million, and 70% of those confirmed cases were children under 5. In 2019, the country, under the leadership of the NPHCDA, implemented its first simultaneous integrated campaign for more than one injectable vaccine. The vaccines in view were measles, yellow fever, and meningitis A, and this was done across 20 states in the country. For the purpose of this case study, we looked at the planning and implementation process of measles and Men A vaccines across 3 states in the country. The objective was really to identify and document lessons and methods of collaborative campaign planning from the planning and implementation of the integrated vaccination campaigns in the 3 states that we looked at. The study locations were really in Kwara States, Niger State, as well as Kogi State. These 3 states are located in the northern part of Nigeria, which still continues to account for the high number of unimmunized children in the country. The study was also conducted at the national level because the high-level planning for the implementation of the integrated campaign was done at the national level, which is located in the Federal Capital Territory. These 3 states and the FCT formed the study population for the study. This study adopted a cross-sectional mixed method approach where focus group discussions were conducted, key informant interviews were also conducted, and a desk review of past campaign planning document processes were also looked at. For the key informant interview, this was administered to technical partners who supported the integrated campaign planning and implementation. Those include WHO, UNICEF, and AFINET. The KII was also administered to government leadership at the national level and across the 3 states that we looked at, and also healthcare workers who supported the implementation and planning of this integrated campaigns across the 3 states. For the focus group discussion, the same was done. This was conducted at the national level with the supplemental immunization activity lead, and also conducted at the state level also with the SIA lead, as well as the SIA implementers at the health facility level. For the desk review, we looked at, we reviewed the pre-planning tools that existed. Some of this include the state readiness dashboard that is really used to make go or no-go decisions for implementation. We also reviewed guidance documents that exist, such as the field guide, and also looked at the harmonized data tools that were used for the integrated campaign. Key findings. We've highlighted 4 key findings from the study, one being the need for strong government leadership and early multi-stakeholder collaboration. Another being an efficient supply and cold chain infrastructure. The third being strong technical skills, and the 4th being funding. I just speak on 2. Technical skills. Part of the things that the study highlighted is the need to ascertain the technical requirements early on to support the planning and implementation process. One of such technical requirements that the country had identified included data management. In terms of funding, financing an integrated campaign could be challenging, and if not efficiently done, it could threaten the successful integration and conduct of the campaign. Part of what is required is an early forecast of the funding required for the campaign, especially the operational cost. This must be done on time to ensure that it is incorporated into any necessary budgetary process, followed by very strong advocacy for fund release. Challenges. So during the course of the study, we had two key challenges, one being conflicting activities for the interviewing with the ongoing COVID-19 vaccination campaign in the country. To mitigate this, part of what we did was to ensure that the interviewee selected the time that was most convenient for them for the interview. Some of the interviews were even conducted virtually. Also, the ethical approval process took longer than we had planned, and to mitigate this, part of what we did was to work very closely with the National Primary Healthcare Development Agency, who helped to expedite the approval process from the country's IRB. A few promising practices also came out of the study. One, the cost-effective digital method for meetings and trainings. As I mentioned before, the planning and implementation of the integrated campaign was conducted in the context of COVID, during the COVID-19 pandemic. And so a lot of the trainings were done virtually, and also the coordination meetings. Part of what that has proven is to be both efficient and cost-effective. And it's a method that the country is looking to adopt for subsequent implementation and planning. Harmonization of the integrated campaign plans, tools, guidance, document, and system is also one key promising practices. Shared accountability, this was critical because the shared accountability between all the levels created a sense of ownership and also promoted the implementation of the campaign in an efficient manner. Increased access by eliminating key structural barriers. Part of what also happened during that integrated campaign was taking the campaign closer to the recipients. And part of what that mitigated was long wait hours, more identification of zero dose, and also reduction in transportation barriers. And finally, early budgeting and funds release. So these are just some of the interviews that were conducted at the health facility level in Niger State, one of the states where the study was conducted. Thank you.
Thank you very much, Ms. Lambo, for that presentation. Obviously, there are some common themes running through the two projects, issues around advocacy at the community, the political and technical levels. There's also the issues around stakeholder engagement, very important for the success of the campaigns, and also issues around strategic, being strategic in the area of our funding. I also noticed that there are quite a number of questions already popping up in the Q&A box. We are taking a look at them, and we will be addressing a few of them during the later in the session. But in the meantime, I'd like to come back to the presenters, and would like to learn a bit more about engaging stakeholders in the planning process. Tell us a bit more about how the different campaign leaders and partners came together, what worked in that process and what didn't work. If you encountered differences, how did you address them and negotiate through them? And also, importantly, how were the perspectives of the community and health workers obtained and brought together in focus? Perhaps we could start with Dr. Onoja from the Ibolda group.
Hello, everybody. Looking at the issues of approaches used in engagement of stakeholders, they include joint meetings, courtesy calls, shared assignments, and also responsibilities. we should note that we did not go to.
Excuse me, Dr. Onoja, if I could just interrupt quickly. If you've got another laptop on in your room, we can hear that echo. So we just need to pop the sound off.
Okay, it will be
if that's all right. And if you also want to invite Dr. Dele to speak, we can spotlight him as well at the same time. So.
Okay, well, can Dele take that?
We can still hear an echo at the minute.
Okay.
Just pop your volume off if that's okay off the second laptop.
Okay, is it clear now?
Yeah, I think let's try again. We'll see if that works. Yeah.
Well, on approaches for engagement of stakeholders, we used joint meetings, courtesy calls, and then we also had an idea of shared and then assigned responsibilities. Then we did not witness any joint activities because what we did was exploratory process evaluation of the two standalone programs to see the feasibility of integration. However, at the national program, through the technical branches, held physical and virtual meetings with relevant states to share the concept with them to get their buy-in. Then there was also joint planning meetings, courtesy calls, appointments of ambassadors, and then flag-off ceremonies, training, monitoring, supervision, and also assessment. Issues of how we addressed negotiated differences in terms of potential areas of negotiated differences. Joint meetings, those were resolved through joint meetings, joint technical committees, because NMEP has both the ITN expert group and SMC working groups. Matters relating to collaborative integrated implementation are discussed at this technical fora, especially in the technical details towards efficiency of EDA campaigns. Talking about the issue of how the perspectives of community and health workforce were obtained through various means of consultation, which includes contacts with traditional and religious leaders, contacts with opinion leaders, youth groups, women leaders, trade groups, through key informant interviews too. Then perspectives of the health workforce are outlined through discussions and interviews with various segments of the relevant sections of the facilities. Then we're also talking about understanding the health workforce and key personnel perspectives on plans towards integrating the two campaigns. The process of micro-planning could include holding meetings of all campaign personnel at the state, local government, and community levels to determine projected population, health facilities and catchment areas, and other projected population route assessments, storage facility assessment, etc. Then joint supervisory activities. The nature of products might make joint logistics a little bit tricky because of timeline of procurement timelines. Then joint training might require harmonization of manuals and increase in training days. Bigger and more conductive training halls might be needed in line with COVID-19 protocols. Training could be done on staggered basis to reduce the number of attendees done in a large hall where adequate space could be observed. Social mobilization could be conducted simultaneously after harmonization of IEC and SBC materials. And then talking about promising practices that can arise from the collaboration, it can bring about an increase in collective demand for both ITN and SMC campaigns. This is due to the fact that integration will create a psychological feel for double benefits, having to receive both commodities at the same time. There's also possibility of cost saving in campaign implementation as overall size will be expected to reduce. Over.
Thank you so much, Dr. Onoja, for those interventions. I'd like to invite the CHI team to respond, make some comments along the same lines around some of the lessons learned around engaging stakeholders in the planning process.
Thank you so much, Dr. Olumide. And I think very similar to what Dr. Onoja had said, something that was very critical to engaging stakeholders in the country was the establishment of the technical working group under the leadership of the NPHCDA. So two things were key, really. There was the leadership that the government provided, and then there was also the technical working group that created the forum for all partners and all stakeholders to discuss, plan, and basically agree and align on the planning and implementation of the campaign. But I'll hand over to Dr. Memunat, who really led this process in Nigeria, to shed more light on how we're able to get stakeholders engaged together, how we got buy-in from the lower level, and also promising practices that we learned. Dr. Memunat, over to you.
Okay, just to let you know, we don't appear to have Dr. Memunat in the room at the moment. I'm just going to double check, possibly a connection dropped off. I'm just going to have another look.
Okay, well, maybe I could take those responses. So I think in terms of how we got buy-in from the lower level in Nigeria, the planning process of integrated campaign is really a top-down approach. However, through the micro-planning process, we're able to get buy-in from the lower level. They contributed extensively to their micro-planning process. That gave them a sense of ownership and a sense of alignment with the program. And that really was part of the main things that helped us get their buy-in. Of course, there were stakeholder engagement from the national level to the state level and the local government level. Other stakeholders who were involved or who had a role to play, such as religious leaders, traditional leaders, youth groups, women groups, the market women, all of them were involved. And so once we were able to get their buy-in on why this integration needed to happen, more often than not, at the lower level, we also got buy-in from them. Key promising practices. One key thing, like I had mentioned before, is government leadership. There are multiple partners supporting this space in Nigeria, and there was need to have that forum where people can come together, agree, disagree, align, share roles, share responsibilities. And I think those were some of the key things that aided the stakeholder engagement and planning of the integrated campaign in Nigeria. Thank you.
Thank you, Dr. Lambo, for that. Just to again remind us and the audience that when we talk about campaign integration, it doesn't always refer to co-delivery of intervention, but it could also involve sharing different campaign components and processes, right from the pre-planning through to the planning, and somewhere along the line also in delivering of the interventions also. Okay, so let me come back again, and we'll be going to the questions presently. But before that, I just want to come back to the panelists again, the presenters, and ask a couple of questions about the issues around collaboration from around the one or two promising practices that it came out from this integration which documented. What did you observe that you think are promising and are things that we can take forward from your results? I'll start again with Ibolda, Dr. Johnson, Ali Johnson Onoja, if you please.
Yes. Thank you very much. Early and inclusive planning with joint harmonization of all the tools and guidelines will be very helpful in integrating the two interventions. Over.
Thank you. Ms. Lambo.
Thanks very much, Prof. Very similar to what Dr. Onoja had said. When you're planning integrated campaigns, you need to also think around those who would actually be delivering those campaigns at the health facility level. And one critical thing to that is to ensure that the integrated campaign planning does not add more to the work they have to do. And so some of the key practices, or one of the promising practices that was critical to us in Nigeria, was making sure that the tools that were used for the campaigns were integrated. What that meant is healthcare workers didn't have to be saddled with that responsibility of double recording and double vaccination, etc. So one key promising practices is really the integration of tools. We are seeing that with the integration of this measles and men A and maybe yellow fever campaign, but we're also looking at the possibility of integrating even tools across the SIA program, the routine immunization program, and more. Thank you.
Excellent. Thank you so much. Before you go, I'll just want to ask you to say a bit about one of the things you mentioned that was around the digital training as a promising practice. You said that in the course of your presentation. There's a question here in the chat box from David asking about how effective this was at all levels, including the community level, and how you address the challenges around connectivity and skill development with digital training versus in-person training. So could you say a little bit about that?
Thanks again, Prof. Honestly, the problems were still there. Internet connectivity continues to remain a problem. Yeah. But one of the things that this did was even bringing the country closer to embracing digital technology, right? So the basic things, you start from the basic things. For example, we weren't even at a point where people had Zoom IDs, for example. But now our healthcare workers all have Zoom IDs, they know to log in. Internet connectivity might be a problem. It is a problem in certain areas, but we're just taking baby steps and doing what we can. However, we did, as part of the planning process, put in mitigation strategies, such as a typical example is there's a particular state where during the planning process, they did have very poor internet connectivity when the training for the integrated tools were done. And so to mitigate that, the national level had to send delegates to that state to support them to address the use of the tool. So with internet connectivity, all I would say is, or rather with digital learning, every step is a step in the right direction, right? But as you continue to promote the use of digital technology, especially for learning for healthcare workers, they get better at it. And yeah, thanks.
Thank you. Thank you. Thank you so much for that. For the Ibolda group, there's a question here around data reporting for SMC and LLINs. So the question is, how was the data reporting for SMC and LLIN campaign managed? Was this integrated? And what would you recommend for future campaigns? Could somebody from the Ibolda group take a shot at that?
Yes, my colleague, Dr. Babarinde, is going to answer that.
Excellent.
We strongly recommend that the two data from the SMC and ITN should be integrated together. But this will take place right from the inception by harmonizing the two that we use to capture the data, which both set now, while integrating, they will meet together and train together as one with the same tool that has been incorporated together. With this, analyzing the data will be easier because the two components have been integrated together right from the beginning. Over.
Thank you. I have a question here, which frankly, I think either of the two teams could take a stab at. It's from Bangladesh, and the question is, currently Bangladesh is having both COVID-19 pandemic and dengue outbreak. How can we plan integrated health campaigns in this context? So basically this is asking for your, what are your thoughts around possibility of planning for integrated health campaign in a situation where, currently we're all dealing with COVID-19, but then there's also a dengue outbreak superimposed on this. So what kind of, what lessons from your experience do you think would be useful in that kind of a context? I think either Ibolda or CHAI can give a response.
Yeah. I can take a stab at it. So I would just say, from our experience in Nigeria, in reality, we implemented our first integrated campaign right in the midst of COVID. Two things. One, healthcare workers needed to feel safe. And to make them feel safe, the country had to do two things. One, they had to educate the healthcare workers properly about COVID, how it spread, and what measures can be taken to ensure that you mitigate the risk to yourself as a healthcare worker. But two, we also had to modify the templates that were used for campaign planning to accommodate PPE materials for the healthcare workers. Traditionally, the country didn't have that. Now, when the tools were modified, healthcare workers were able to support the quantification process of what tools they needed for the period of the campaign and those type of things. So those two things, one, educating them, and two, ensuring that they see that their safety is priority and paramount, played a critical role. Now we're beyond that in the country. Healthcare workers are getting vaccinated now with COVID vaccines, but prior to now, those were some of the steps that we took. Thank you.
Thank you so much. Any thoughts from Ibolda?
In that situation, the use of virtual options can also be helpful. Many of the physical meetings under that kind of scenario can be virtually held. And then all elements of emergency preparedness and response are also put in place to ensure that, as Dr. Lambo said, the programs go on despite the epidemics. Over.
Thank you. Obviously, one of the things that we all as a global community are learning to do more and hopefully better is to use virtual approaches to addressing some of the issues we have to face in terms of training, meetings, coordination, and those kind of issues. I have a question here for Ibolda, I think, and the question is, in what context could the promising opportunities be effective? How can stakeholders come to consensus regarding responsibility sharing, and is this feasible or is it prudent? I mean, when you in the case of SMC and LNIN campaigns, obviously there has to be some agreement on who's responsible for what and how those will be shared. So how feasible and how prudent is it to do this, and what kind of challenges did you encounter, if any?
From our end on the field, we found out that both parties, the SMC and the ITA, they were eager to collaborate and to integrate. But nevertheless, we will recommend for now at the start partial collaboration and partial integration. And as I said earlier, this will start from meetings among the stakeholders, courtesy course, training, and all the stakeholders at highest level and lowest level has to be carried along with the promising practices that will emanate from the integration, which we believe it will save costs, and also because due to that integration, it will create a psychological feeling for double benefit, having to receive both commodity at the same time, and possibly it's cost saving, because some of the activities they are carrying out right now is more of duplication. Over.
Thank you, Dr. Riley. That's I believe that's helpful. While I still have the Ibolda team on the floor, there's a question also around the scheduling. SMC is 4 times a year, LNIN is one distribution. So the question is, how do you manage this in terms of the scheduling and the integration?
As we explained earlier, we've not done integration, we just did a process evaluation. And then that's why we're recommending partial integration when the circles meet then all components should be realistically integrated. And that will bring all the benefits my colleague had earlier enumerated. But when the circles do not meet, then the two programs they stand as it were. So in the process of discussion, there was no obstacle to the willingness of both programs to integrate when the circles meet. Over.
Thank you. Thank you very much. Ms. Lambo, I'll come back to you now with a question that's been asked by Carol. So the question has to do with accountability at both the national, state, and district levels. So how was this shared accountability achieved? And what was the sense of shared accountability? How was it different when collaborative planning was conducted? And if it was different, what do you attribute this to?
Thank you very much, Prof. I would say that accountability for the campaign, for the integrated campaign, was built in very early on from the planning phase. And this relates to another question that was asked around what are the pre-planning tools that were used. The country had designed a tool called the State Readiness Dashboard. Now, what that dashboard does is to identify responsibilities of the multiple levels of government that contribute to the integrated campaign, what their responsibilities are and how far they've gone doing it. So everyone at every point knew that to achieve the target that we want to achieve, the local government has XYZ role to play, the state government has XYZ role to play, and the national government had XYZ role to play, and these roles had to be played within a certain time frame. With that, everyone was responsible for being accountable of some sort to the campaign process and also to the success of the campaign. And one critical thing that was instituted in the country in 2018, which has continued to follow through, is the use of that system to actually make go or no-go decisions for implementation of the integrated campaigns. So based on the accountability system that was established, has everyone done what they are supposed to do? What is the percentage of completion of what everyone is supposed to do? And should we go on to implement in this state based on the current status of the framework? Thank you.
Thank you very much. So obviously, excuse me, obviously one thing that's coming across also is the importance of leadership in this whole process. That's going to lead me to focus on two questions which basically address issues around the community. And one is asking if you faced any challenges at the community level, with the staff during the implementation of the campaigns. And the second one has to do with how you engage leaders at the community level. I'm going to ask that if you both could take a stab at this question, your different perspectives. Ms. Lambo, would you like to go first?
That's fine. Thank you again, Prof. I think, engaging stakeholders at the community level, based on the country's experience, is something that was, again, done very early on in the planning process. Typically, what is done in the country is all the necessary stakeholders are identified, and there is typically a forum for them to sit, be educated on what needs to be done, get their opinion on how they think this should be done, and generally just agree on next steps and who should be responsible for what. It basically takes me back to shared accountability. Even the stakeholders, such as the community leaders, the religious leaders, all had a role to play, and everyone was clear on what that role is supposed to be. If you are able to get the buy-in of those people who are critical to, I would call them the gatekeepers really, at the community level, once those gatekeepers are bought into the process, oftentimes the community themselves would buy in, because these are really the people they listen to, right? These are the people that they seek advice from. These are the people that gives them direction. So your first step is really getting those people on board, establishing a forum, explaining to them what needs to be done, but most importantly, hearing from them on how they think this can be done successfully and taking all those into consideration. Thank you.
Ibolda.
Yeah, about community engagement, NMEP has a well outlined and robust community engagement process that works in all the communities. And with the leadership they've provided over the years and then community reception, it was not difficult at all to engage the community. And then one thing to note, however, is the fact that in operations, there could be little variations here and there in terms of community engagement, selection of key staff to participate. But it goes through the normal processes and then they are always resolved. Over.
Thank you very much. Coming closer to the end of the session now, I think we would just look at a couple of questions more. There was a question here. Again, this is going to go to Ms. Lambo, I believe, about the challenges with regard to community acceptance of measles, meningitis, yellow fever, I guess, campaigns. Were there challenges with regard to accepting these campaigns in the community, and if there were, how were these addressed?
Thank you again, Prof. I would say there will always be challenges, and that's where your social mobilization, strong advocacy comes into play. In Nigeria, sometimes we have the highest level of government come out on the platforms that have been identified to be targeted to the areas where we're trying to communicate these messages to advocate for why this vaccination is important. So I would say there will always be pushback. It happens with almost every vaccination program, especially at the community level. But you continue to advocate, identify the right gatekeepers for those community, explain it to them in the language they understand. And I do think that those are some of the strategies that would help. Minkop, you can shed more light on this if you want to. Thank you.
Is there an intervention from Minkop?
If Minkop would like to pop her video on, that would be great. Just wait a second. Just see if I can send a message. Unfortunately, there's not an answer, Prof. So we'll move on.
Okay,
Thank you.
That's fine. Well, did you have any issues around SMC ITN integration also? If yes, what was your experience and how were these mitigated?
Please come again with the question.
I was asking if you had any issues in terms of acceptance with the SMC and ITN integration, and if you did, how was this addressed? I know that you had mentioned in your presentation that one of the things that if you like was promising practice here was that the fact that these two campaigns went together increased the demand for the two commodities, because we were seen as a double benefit, so to speak. But was there any community or situation where there was some pushback from the community regarding this intervention?
Thank you, Prof. Once more, as we said, the integration has not actually taken place, but at all the levels, both at the lowest level and national level, they were all excited to see this thing coming to pass for now. But we do not say, because we have not witnessed it. So we cannot envisage any trouble. But nevertheless, peradventure there is any issue that may arise, it is highly surmountable because the reception and feeler we got from the interview we carried out and focus group discussion in the field, you are all eager to see it coming to pass. Over.
Thank you. Okay, as we come to a close now, I'd like to ask if you could share some thoughts, just in less than 1 minute, one reflection or recommendation you would have to enable more effective campaign collaboration in Nigeria.
Prof, could you please say that again?
Yes, I said I'd like you to make some final reflections, recommendations or comments on one recommendation, if you like, which you think would enable more effective campaign collaboration in Nigeria.
I would say planning all over again. You cannot over plan, you can only under plan. Planning is critical to implementation of integrated campaigns and even programs. Generally, you have to be able to identify what the needs are, what the targets are, and what you actually need to efficiently implement that integrated program campaign. That is really critical. Once the planning process is done right, that automatically takes you a step closer to achieving the results that you had set out to. Thank you.
Thank you so much. Ibolda?
Yeah, from our own end, we will summarize everything by saying early and all-inclusive planning with joint harmonization of all tools and guidelines go a long way, and we strongly recommend it. Thank you.
Thank you very much. I think this has been a very informative session, quite a number of useful lessons learned. We've heard about issues around how important it is to plan, both pre-plan and also to plan actually the delivery of the integration itself. In the course of the planning, obviously, you will be looking at engaging the stakeholders, which is also very important, engaging them very early on. Planning will also involve issues around your advocacy at the community, the political and the clinical level. Planning will involve issues around your funding strategy, mobilizing the resources from the different stakeholders and the different funding partners, if you like, at the national and at the state levels. So yes, I can't but agree with you that planning is very important, and you really can't over plan. The use of technology is also, I think, from what you said, potentially helpful tool, which I guess in the months and the years ahead is going to become increasingly important as we go further down this road. I'd like to thank you all for giving us a very, very enlightening presentations, providing us information about what you have done. Basically, it's really very hot off the press. This is the first in the series of the projects that have been funded along those lines, which we are listening to. And you've been very, very thorough in putting together and articulating your thoughts and what you have documented. So I'd like to thank you all very much for this. At this point, we would like to now hear from some of the national agencies, and I'll turn over the floor to Eva from the task force and its HCE coalition to introduce the speakers and take it from there. Thank you so much.
Thank you, Professor Olumide. Hello, everyone. I'm Dr. Eva Bazant, Senior Associate Director for Implementation Research at the Coalition Program. Next, we are going to hear some remarks from distinguished speakers. First, I would like to introduce colleagues of the National Malaria Elimination Program, NMEP. Dr. Perpetua Uomuibi is the Director and the National Coordinator of the NMEP, which is in the Federal Ministry of Health. Dr. Uomuibi has over 20 years of experience in public health programs, research, surveillance, and monitoring evaluation, having supported the development of the National Malaria Strategic Plans and the M&E plans, among other documents, and coordinated the implementation of several large surveys with biomarkers and authored publications. And she will be followed by, briefly, Dr. Philip Okefu Oyale Okoko, the head of the Integrated Vector Management Unit within the NMEP, and also with 25 years of experience across diverse disease programs. So over to you, Dr. Perpetua.
Okay, good afternoon, everyone. And it's my pleasure to be here. So we at the national program looked at the context and implications of the findings on this exploratory process evaluation that was carried out by Ibolda Health in collaboration with the National Malaria Elimination Program. Next slide, please. So we already have heard from the speakers, Ibolda Health and the other presenter from CHI. So I would just like to start by saying that insecticide-treated net campaigns and seasonal malaria chemo prevention two key interventions that the National Malaria Elimination Program deploys as part of its vector control and chemo prevention strategy within the National Malaria Elimination Strategic Plan. And currently, the vision of this strategic plan, of course, is in malaria-free Nigeria. The goal of this current strategic plan is to achieve a malaria parasite prevalence of less than 10% by 2025, and to achieve malaria attributable deaths to less than 50 deaths per 1,000 live births by 2025. Whereas, of course, achieving elimination and elimination status, hopefully by 2030, in line with the global technical strategy. We have similarities in both of these interventions because we have seen that in terms of the pre-planning process, high-level advocacy that are paid to the states during the planning, the implementation, and even during the post-campaign processes. And also the fact that both interventions actually targeting protection of the beneficiaries from malaria. And so the beneficiaries would see it as a double protection. Campaigns could improve coverage intervention. We have seen over the years that when we implement seasonal malaria chemo prevention, for instance, the eligible local government areas in the country, we usually achieve over 100% because it's well received. The caregivers of the children under 5 that are targeted will even come across the local governments that have been targeted and are coming from benefits to their wards and their children. So it's something that we have seen over time that is embraced by the beneficiaries. Next slide too. So we think that both interventions, when the mobility and severity of malaria in children under 5, and also more recently, because we have had to adapt the LLI and the ITN campaigns to the COVID pandemic from the fixed point distribution approach, which we used to do, to the door-to-door campaign. And we know that the seasonal malaria chemo prevention campaigns are actually door-to-door campaign. So that's also, that's already a similarity in the mode of distribution. So when you are able to then bring this intervention to the households at the same time, it's a potential source of improving coverage intended impact. So what are the other contexts that we have seen? We think that it's wherever it's feasible, we should look at integration. So what most of the questions that were asked initially, have we actually set out to do integration in the country? No. But the Zamfara campaign, the ITN and the SMC campaign that was done was actually born out of necessity during the COVID due to some delays in arrival of the commodities. So there was a shift in the timeline. And so those two interventions happened at the same time. And so some lessons were learned from that, and that it's actually possible to set out to do integration and you can achieve success. And also when we also did the piloting of the vitamin A supplementation with the SMC integration, also that was done last year in Sokoto. Looking at these two scenarios, begin to look at integration of some of these campaigns with other health interventions, because we also know that the personnel that are needed in the state and local government level, actually there's overlap. It's the same health personnel that are needed. So rather than overburdening them, and as well as the same time you're saving costs, why not go the way of integration if possible? And of course, like everyone has been saying, early engagement with all the key stakeholders, whether at the national level, or those implementing, and at the state level, is essential to achieve a success, and also to get buy-in when you want to embark on such integration. Of course, another facilitator would be availability of early arrivals of the commodities that are needed, whether it's the nets or the sulfodiazine, pyrimethamine, and amodiaquine for the seasonal malaria chemo prevention. Because availability of funds is also critical to having successes. Next slide, please. So at the program, we believe that some of the strengths of this integration is when you have the state joint in terms of at the state, that's the governor, the commissioner of health, and at the local government level is the same personnel. The officials are the same. So if we want to integrate, if we want to go do those campaigns, why don't we do it at the same time? And then the message, the behavioral change communication messages can be combined for both campaigns using the same media platform, and that can potentially save costs of the campaign. Of course, during the planning process, the micro-planning process and all that can be done jointly as well. And we've also talked about if you potentially deploy e-technology for data capturing, that will also help towards integration and supervision and monitoring of both interventions. Another area is looking at the Zamfara campaign, strong coordination mechanism by the national program with donors and implementing partners and the State Ministry of Health would also ensure that we have successes with this integration. And for instance, now, just to mention, we are implementing seasonal malaria chemo prevention and LLI ITN campaign in Gombe State. And we actually, with the states, planning a joint campaign flag off on Monday next week, so by the governor himself. So the state actually proposed that since both interventions are occurring at the same time, why don't we have a joint campaign flag off? And so we are working with them to do that. So that's like killing two birds with a stone. And so that's something that we are actually looking forward to and excited to do that with the state. And of course, I've mentioned the area of the beneficiaries looking at this as a double protection, receiving both nets at their household level, at the same time receiving the sulfodiazine, pyrimethamine, amodiaquine tablets for their children to protect from the same disease, in this case, malaria. Next slide. Okay, so so basically those are the things.
Dr. Perpetua, I think we need about one more minute.
Okay, sure. Yeah, so basically those are the main things that we are looking at integration. We think it's a good idea. We are going to begin to explore how we can do this, both for not just for malaria and for malaria, because in this case, we are looking at seasonal malaria chemoprevention. At the same time, ITN distribution, which is for the same disease, but even across disease programs, where, for instance, we did that with vitamin A supplementation in collaboration with the National Primary Healthcare Development Agency. So we can begin to do that with even with other campaigns, whether it's measles campaign or other health campaigns. We think that there are potential areas for doing that. And but of course, the challenges are still there, looking at insecurity issues. And then, for instance, when you have to target, you have different target groups that you are targeting for implementation. That could be a challenge, but there are also ways that can be managed potentially. I think those are really my intervention at this time. But also that thank you.
Thank you so much, Dr. Perpetua Uwamuibi, Director of the NMEP. And we have one additional distinguished speaker, and this is Dr. Faisal Shwabu, is the Executive Director and Chief Executive Officer of the National Primary Healthcare Development Agency, and also a leadership team member of the Health Campaign Effectiveness Coalition, with a long and distinguished career, having worked in polio eradication, among other diseases in Nigeria. So we'll turn it over to hear Dr. Shwabu.
The chairperson of the meeting, members of the Health Campaign Effectiveness Coalition, distinguished ladies and gentlemen. First, I wish to sincerely appreciate the Health Campaign Effectiveness Coalition team for this great opportunity to share with members how Nigeria is using campaign opportunities as a tool to strengthen the broader routine immunization and primary healthcare systems. The vision that we have for cross-campaign collaboration will be where we can better have bottom-up planning and coordination to ensure that there's clarity around the possibility of integration of campaigns, especially where different antigens that may be needed cannot be utilized together. For example, there are antigens that need to be given within some days or weeks apart. Coordination is very important so that there's an optimization of the complementarity that exists between the different campaigns. And it also provides an opportunity to bring in add-ons such as anti-helminthics, bed nets, and in some instances, what we call pluses, which are provided to attract clients to the service point. The use of technology for micro-planning, data collection, and analysis contributed to an improvement in the quality of campaigns conducted. GIS maps are used during micro-planning processes, and they contribute to identification of new settlements with eligible target populations. GIS is used to coordinate and identify defined populations that can be targeted. There are, of course, situations where different populations are targeted for different campaigns. Now, in terms of monitoring and supervision of campaigns, we're enhancing the quality of supervision by doing GPS tracking of supervisors. Again, this uses GIS. This is to ensure that supervisors are actually in the place where they are supposed to be. Our experience from the polio eradication program shows that the benchmarks for quality of a campaign is the quality of supervision in ensuring that we track folks that are going for supervision and they are where they're supposed to be. The use of ODK and GPS tracking of monitors during campaigns contributed to an improvement in the quality of monitoring and supervision during campaigns. Data collected during campaigns are usually analyzed and used for immediate action. We're also using lot quality assurance sampling, LQAS, to assess the quality of campaigns, and from that, we know which areas require a repeat of the campaign. The cross-integrated campaigns experience is being used to modify how routine immunization outreaches are being conducted. The states or LGAs are now being supported to implement the optimized integrated routine immunization sessions, OIRIS, which now includes RMNCAH plus N. The routine immunization outreaches are to be integrated with other services. tertiary and secondary institutions are also able to provide daily integrated services. COVID-19 vaccination is also being used as an opportunity to provide integrated services. In addition to the vaccination, health talks, screening for hypertension and diabetes are also carried out at the sites. Children are also screened for malnutrition and administered their routine immunization vaccines. Now, in terms of demand creation, the country will continue to involve religious and traditional leaders in the planning and implementation of campaigns and routine immunization in order to improve awareness. The Community Health Influencers, Promoters and Services, CHIPS, was created to improve demand for, access to, and equitable coverage of essential health services, especially those related to maternal and child health at the community level. It is also to drive the very important aspects around community education, educating communities around issues that are related to antenatal care, deliveries, routine immunization, growth monitoring, and other health-related discussions. The federal government of Nigeria is making a lot of efforts to collaborate across different campaign programs, as well as work more towards integration with other broader PHE services. Using the lessons learned from the polio eradication program and other campaigns conducted, we are better equipped to optimize future campaigns, strengthen routine immunization, and improve the primary healthcare systems. I thank you for this opportunity to be part of this very, very important seminar. Thank you.
We have some opportunities for further engagement and a poll, but just before doing that, I would again like to thank our distinguished speakers, Dr. Schwabu, Dr. Uomuibe, Dr. Oyale, and Professor Ogunda Hunsi, as well as Drs. Ali, Dele, and Ms. Lambo from our presenter teams. And all of you listening in and participating today and asking questions and contributing to the chat, we really thank you for being here today. So if we can show the one last slide, I think this is the last slide, opportunities for further engagement. I'd like to invite you to visit our website where we do have an early beta version of the Decision Guidance Toolkit for People-Centered Integration of Health Campaigns developed by our Campaign Integration Working Group and our Secretariat. So we do also appreciate your feedback on the tool, and you can do that right there on the website. Please join us again when we continue this conversation and many other conversations at our annual coalition meeting next month, October 19th, 20th. It'll be similar to this type of format. And so please register today to get more information. And these two presentations you heard today will be produced in a case study document format in the next month or two and be up on our website. And then we have 6 additional projects, and many of those colleagues that are working on those case studies have been joining us today. So we have projects that we're supporting being carried out by institutions working closely with the national governments in India, Nepal, Colombia, Ghana, and Guinea. And this is in the area of potential integration or past integration related to NTDs, neglected tribal diseases, vitamin A, immunization, and polio. So we'll have additional lessons, and I'll look forward to working with all of you and hearing from you about what are the key topics you'd like to hear about in the future as well. So until next month, we'd like to again thank you for attending, and thank you, and yeah, have a good day. Oh, I'm sorry, we have a poll. So the poll is on collaborative planning of campaign integration. Do you have knowledge of a country experience or tools to share? And so we'd love to hear what you have to say. And I think it'll just take a second to get a certain number of respondents. I think we can probably share the okay, great. Yes, again, similarly, we have a knowledgeable, experienced group, almost half of you, and then those that are very interested. So this bodes well for continuing the conversation. Thank you so much for joining this seminar on Nigeria. We look forward to talking with you again.
Thank you, Eva. On behalf of the MIT events team, it's been our pleasure to support you today. And thank you again to all of our speakers and to everyone for joining us. And we will now end the webinar. Thank you very much.